this little pill, I don't know how well you can see it, but it's a tiny pill, and it has saved about 100,000 lives per year. Really. It's because of its ability to prevent clots, the clots that might end up causing a heart attack. But in the last few years, people have stopped taking this little pill. So why are people stopping now? Isn't it relatively safe? Isn't it something that, it's an over-the-counter, right? Here's what happened. In 2022, the U.S. Preventive Services Task Force changed its recommendation for aspirin for prevention of heart attack and stroke. What they said was not everybody should take it. Now, again, if it's so harmless over the counter, and if it's saving lives, what's going on and why is this happening? We'll get into the misunderstanding in this video. We'll clear that confusion. We'll talk about how to use aspirin to clear your arteries, prevent heart attacks, prevent strokes. And most importantly, once you begin to understand this, we'll also talk about when to not use aspirin. We'll talk about alternatives. We'll talk about medications and natural supplement alternatives as well for blood thinners. One of the places that we're going to talk about is atrial fib. And we'll talk about atrial fibrillation, what it is, and why it is so important in the aspirin story. It is, in fact, that place where you need to know that's not the place to use aspirin. And we'll talk about why. We'll also talk about Lp(a). What is it and why? What's the Lp(a) wrinkle in the aspirin story? So grab something to drink, preferably in a steel cup or glass, not plastic. And let's get started. My name is Ford Brewer. I'm a preventive medicine doc. I started off as an ER doc, and it just drove me crazy that so many people were having heart attacks and strokes and other things that coulda, woulda, shoulda never happened. So I decided that I was going to become something I didn't think I was going to do. I was going to go into prevention. I've had 40 years of experience in preventive medicine. Now let's get to the basics of aspirin. You need to understand three things. The first is, what is aspirin? Part of the aspirin story is, how does aspirin work? That's the second thing you need to know. The third thing you need to know is the side effects and whether or not it's as harmless as people think. First of all, what is aspirin? In 1897, Felix Hoffmann, a chemist, discovered a compound that went on to become known as Bayer aspirin. He worked for a company called Bayern, and again, the rest of the story is history. But this was not an accident in the lab when Fleming discovered penicillin because some bread mold, flew in his window. This was an example. In fact, the first example of Big Pharma doing what Big Pharma does so well. They knew of a natural remedy that was working, and they decided to make some changes in it, maybe recreate it in the lab, and make a ton of money in it. You see, aspirin had been known for 4,000 years. Not 50 years, not 100, not 1,000, 4,000 years. The ancient Sumerians actually noticed that if they took the bark of a willow tree and boiled it, it decreased fever and it decreased pain. So that's what Felix Hoffmann was going after. Just a few years before Hoffmann made his discovery, the compound in that willow bark was discovered. It was called salicylates. And for those of you who might know this or have an interest, what he actually created was acetylsalicylic acid. So how does aspirin work? One effect is it improves pain. That's what the Sumerians noticed, and that's what Felix was going for. But there's another effect, and that's what we're interested in today. It's decreasing clots. Aspirin binds to platelets, the little things that start the clotting process, the platelets in your blood. It prevents platelet activation. Other blood thinners, like warfarin, like some of the natural blood thinners, have more of an impact on the clotting cascade. Clotting cascade is a series of a dozen proteins which form together to create a clot after platelets form a lattice work to start the clot. Warfarin and heparin, you've probably heard of those. Those are what we call vitamin K-dependent clotting factors. That's clotting factors 2, 7, 9, and 10. The NOACs, novel oral anticoagulants like Xarelto and Eliquis, focus on one clotting factor alone, 10A. That's a little bit about how it works, and thank you for your patience as we got through that geeky part. Side effects. Now, what's the problem with that aspirin? As we said, it's over the counter, so that means it's safe, right? Maybe not so much. In fact, I often say if the FDA were to review aspirin and metformin now, they might make, if they were smart, which is not always the case, they might make metformin over the counter and aspirin a prescription drug. Why is that? Well, there's some side effects. First one is allergic reactions. Another one is stomach ulcer, gastrointestinal bleeding. But the major side effect, the one that caused the U.S. Preventive Services Task Force to change its recommendation, is bleeding. Again, bleeding in the gut is by far the most common, but there have been episodes of bleeding in the brain as well. So here was the previous recommendation. Before 2022, the U.S. Preventive Services Task Force said 60 years and older, everybody should take aspirin because you've got risk for heart attack and stroke. If you're curious about my recommendations, no, I didn't recommend that. My recommendation was not unless you had plaque. If you had plaque and no matter what age you were, you needed to consider aspirin prevention. If you didn't have plaque, no matter what age you were, you needed to not. You didn't have to worry about considering aspirin. And guess what? The U.S. Preventive Services Task Force changed their recommendation to go to what I had been using prior to that. So I'm obviously proud of that. Now, this starts to get into what we call primary prevention versus secondary prevention. Why is that important? When the previous U.S. Preventive Services Task Force recommendation was for primary, meaning even if there's no signs or symptoms of a disease, that's primary prevention. Secondary prevention is you already have a sign or symptom of a disease. So what's the difference between primary and secondary? Why separate those two out? With primary, there's much less risk of continuing on in the disease. Once you already have shown your first sign or symptom of disease, you are much more likely to develop it further and further and further. So that was the issue here. Once you understand the difference between primary and secondary prevention, you begin to understand how the U.S. Preventive Services Task Force really changed their recommendation for aspirin. What they did was they went from a primary prevention recommendation to a secondary prevention recommendation. As I mentioned, my recommendation had always been secondary prevention only, never primary. Why did they do that? Because there's been some improvements in cardiac disease, mortality, death rates, disease rates associated with cardiac disease. And it got to the point to where this risk of GI bleed, this risk of brain bleed associated with aspirin, it was just no longer worth that risk because of decreasing risk of heart attack and stroke in a primary prevention population. So the U.S. Preventive Services Task Force said the juice is just not worth the squeeze for people over 60 for primary prevention. Now, the problem was, and here's where the confusion came in, reporters like the New York Times, a really smart physician reporter, still didn't pick up the distinction here. He said, U.S. Preventive Services Task Force doesn't recommend aspirin anymore for cardiovascular disease prevention. No, they don't recommend it for primary prevention anymore. They still do recommend it for secondary prevention. And here's one of the other things you should consider. By the time we're age 60, what portion of us have plaque already? The majority. So, again, just boatloads of confusion piling on this change in recommendations. Here's the problem. It was misinterpretation, and again, it was based on the difference between primary and secondary prevention. Now, as I mentioned that, let's think about some really good examples. You may be aware of it already. What if you're having a heart attack? Don't the recommendations still say, take an aspirin? And in that case, not even a baby aspirin, a full adult aspirin. While I'm here, and while I bring that up, this is a good time to just mention the differences. Baby aspirin is smaller. It's 80 milligrams. Adult aspirin is 2 to 4 times that amount. It's 160 to 25 milligrams. So yes, if you're having those symptoms, you think you may be having a heart attack, the 2 things to do: call an ambulance to get to the ER, to take you to the ER, the hospital, and take an adult aspirin. That still saves a lot of lives. Doesn't sound like it's that complicated at this point, does it? But we did. Our culture screwed up, confused that whole thing. Let's go a little bit deeper in terms of understanding secondary prevention. There's some words that you'll keep hearing and seeing. Now, when the American Heart Association task force on this started defining secondary recommendation, they started using things like previous heart attack, plaque in your arteries, peripheral plaque down in your legs, plaque up in your coronary arteries, the arteries of your heart. And there's some things that you may hear already, a couple of patterns that you may notice. These patterns are plaque and ischemia. Again, I'll give you a couple of definitions. Don't worry too much about them. The definitions basically say if you have plaque, you should use aspirin because you're now in secondary prevention. Ischemia was a word that I used too, and it's 50% or more blockage of blood flow. Don't wait for that level of blockage. Don't wait for a stress test. If you've got plaque, start taking baby aspirin. Now, I've used the term plaque a couple of times. What is plaque? It's worth describing that. Most people think plaque is a waxy substance or a fatty substance on the inside of the artery, what we call the lumen, where the blood flows. Both of those are incorrect. It's not a waxy substance until it stabilizes. The plaque that's dangerous is a goop. It's a mucus. It's like snot. And it's actually the same thing as a mucus or a snot because it's full of inflammatory cells. These cells and the inflammation liquid that goes along with this goop, this mucus, they trigger clots. So when they squeeze back into the blood flow, they form a clot. They trigger a clot, and it's the clot that causes the heart attack or stroke. If it's big enough and the clot goes to the heart, it's a heart attack. If it's big enough and it goes to the brain, it's a stroke. And some people have microscopic levels of plaque showering in their bloodstream all the time. That can lead to, after months and years, that can lead to heart failure or dementia. Microscopically, the tissue of their heart or their brain starts to look like Swiss cheese with tiny microscopic holes. Now you're beginning to understand another concept. This whole issue, this risk, does not depend on the amount or size of plaque. You don't have to have 50% blockage or more. That gets back to that concept of ischemia. Ischemia comes from a Greek word meaning stopping blood flow. That requires 50% or more blockage of the artery, the lumen, the place where the blood flows. Now, again, you don't need that much to form a clot. That's the common misunderstanding. It's common sense, and unfortunately, common sense is wrong in this area. You don't need 50% blockage for this to happen. So here's what my recommendation is. Who should consider aspirin? Regardless of age, I recommend baby aspirin, 81 milligrams, to anyone who has no allergy to aspirin, low risk of bleeding, obviously, but has any evidence of cardiovascular plaque. If you have plaque and you don't have allergies or special bleeding problems, you should be taking a baby aspirin. All this brings up the most common procedure for heart attack risk, and that is, hey, doc, my uncle had a heart attack, and I know I'm a little bit overweight. Why don't we just do a stress test to make sure I'm not going to have a heart attack? That's not the way to do it. It's common sense to say, let's do a stress test and let's see if I'm at risk for a heart attack. That's not the way it works. A stress test only show any kind of problem if you have more than 50% occlusion of blood flow. Is that starting to ring a bell? You remember we talked about that a few minutes ago. The Princeton Longevity Center said 2/3 of heart attacks occur before you have 50% occlusion of blood flow. So why are we depending on stress tests? It's unfortunate, but I'll tell you, number one, it's something that we all assumed would work, the doctors and patients. And unfortunately, it's too lucrative now. It makes too much money for the clinics, for the doctors. They're not going to stop recommending it. The American Heart Association, the American Boards of Internal Medicine, all of the leadership groups in this area have said way too many doctors are doing way too many stress tests. Now, you may be thinking, well, Ford, what do you do? Sometimes this gets a little bit confusing. You're telling us a whole lot of facts. Why don't you tell us what you've done? Okay, I will, and I have. I've gone into significant detail about my own story. When I retired the first time, again, back about age 53, I was introduced to a fellow named Brad Bale and Amy Doneen, a couple of people. They were traveling the country teaching their way of preventing heart attacks and strokes. They kept talking about a test that was non-invasive, inexpensive, and told you whether or not you had soft plaque. That's the key. So it's called a CIMT, Carotid Intima Media Thickness Test. So I thought I was going to ace that CIMT test because I'd been eating low fat and doing marathons and, some of the things that I needed to change. I was wrong. I had plaque, and I decided to start baby aspirin. I looked deeply at my own lifestyle and made a few changes. And a little bit after that, I discovered I had prediabetes. So if you want to see the rest of that story, we're not going to go all the way down that bunny hole, but if you want to see the rest of that story, I'll show you at the end of the video how you can do that. Aspirin's a life-saving tool, but one of the things you need to know is when not to use it. And I brought up the point of atrial fibrillation. So let's talk about atrial fibrillation and why that's an issue. First of all, what is atrial fibrillation? Here's a short version of it. You've got the 4 chambers in the heart. The 2 on the top, the atria, and the 2 on the bottom are the ventricles. The ventricles are the workhorses. If ventricles don't work, you die within a minute or so. Here's what the atria do. They basically they assist the ventricles by loading the ventricles up and getting them ready. If the atria don't work, it's bad. It's a 20% decrease in the performance of the heart. But it's not going to kill you, or at least not kill you immediately like ventricle problems will. What's fibrillation? So instead of a normal coordinated heartbeat, with fibrillation, the heart loses its normal beat and starts to go into a quivering. That's what happens with atrial fibrillation. The ventricles continue to contract with a normal heartbeat, but the atria are quivering. Now, what's the problem with that? That multiplies the risk of stroke by 5 to 8 times. Most cases of stroke in the past have gone undiagnosed. We called them cryptogenic stroke, meaning we didn't know what causes it. Now, beginning to find out more and more that these are coming from atrial fibrillation. Now, so let's get back to the point. Why doesn't aspirin work for atrial fibrillation? We don't know, but there is some assumption that it's because of the clots are being formed in these atria that are quivering, and for some reason, those clots are just not susceptible to this mechanism of this anti-platelet mechanism that you see for aspirin. Aspirin's just not good for prevention of atrial fib-related strokes. No clear reason, and it may be what I just mentioned. You see, I have paroxysmal atrial fib. Paroxysmal means it comes and it goes. And the vast majority of atrial fib is this paroxysmal kind. In fact, it's sort of like prediabetes. We knew a lot of people had it. We knew that it was killing a lot of people. But it wasn't until we really started testing more and finding that as we age, the majority of people develop this. The same thing is happening with atrial fib and its risk of strokes. We knew that atrial fib was a major cause, the major individual cause for strokes. We also knew that atrial fib was common. By far the most common rhythm problem with the heart, we knew is much more common as you get older, much more common with people that have prediabetes and diabetes. But we had no clue how many people actually have atrial fib. We still have no clue, but we're finding more and more and more. So back to my atrial fib story. 5 years after I started aspirin, so back at about age 55, 57, I noticed I had the CIMT at the Bale and Deneen event. So I started taking baby aspirin. And then that's when I discovered about 5 years later that I had atrial fib. I was using a home device. It's called iCardio. These devices are available on the internet, online, even places like Amazon. Apple Watches even have these things now. They're about $100. You see, I had felt these palpitations occasionally over the previous years. So I suspected that I might have atrial fib. I had also had some genetic testing indicating I had a genetic variation called 4q25 that put me at risk for atrial fib. I was also an endurance athlete, also creating increased risk for atrial fib. I also found out that I had prediabetes, increasing my risk for atrial fib. One night, after I had bought this iCardia, I woke up and my chest was it was like a fish was in my chest. You know, when you catch a fish, you pull it out of the water, it's just flipping. I took my pulse. It was 150 and irregular. A pulse that's between 100 and 200, and especially a pulse that's irregular, those two things are major tip-offs for atrial fibrillation. It was 2 in the morning. I knew I had a lot of risk factors for atrial fib. I'd had a few palpitations. I got up. I had a pulse of 100, a lot of flipping in my chest, a pulse of 150, irregular. I used that iCardia. Yep, I had atrial fib. So tell me on a comment if you would like to get further. I'm not going to go much further into this whole atrial fib story, but give us a comment if you'd like for us to do that. I actually have a series of videos for those of you who are interested in atrial fibrillation. And if you're not, because you think, I'm not going to be touched by atrial fib, you might be one of those people that also thinks you're not going to be touched by prediabetes, and you might need to think again. So if aspirin doesn't work for stroke prevention with atrial fib, what does? NOACs. It's a new type of prescription blood thinner. NOAC stands for NOAC, New Oral Anticoagulant. They're better. They're better than aspirin. They inhibit thrombin or factor 10A. You may remember me mentioning that. In that coagulation cascade, those proteins that fill in the clot once the platelets have created a lattice work. Common names for these NOACs are Xarelto and Eliquis. So if you're watching this video, many of you have already heard of NOACs, Xarelto, or Eliquis. Now, I mentioned earlier on that I was going to talk about natural options for blood thinners. Those are for people that don't want to take medications. Prescription medications, are usually prescription because they have risks. The NOACs are no exception. They do have risks too, but many of us would say after you get deeper into the NOACs, they may actually have less risk than aspirin. That's a different discussion for a different time. Let's go back to the natural options. Fish oil, for example. Fish oil or omega-3 oils decrease platelet membrane stickiness. You may have heard that fish oil or omega-3s are natural blood thinners. Serrapeptidase or serrapeptase, depending on how you define it, decreases or actually cuts up the fibrin in a clot. Ginger, garlic, nattokinase, turmeric, all of these have antiplatelet functions. I take them. They have benefits. But the bottom line, you're not going to like hearing this. I didn't like hearing it either, and I'm going to get a lot of hater comments. The natural ones are not better than the medications, especially for atrial fib and stroke prevention, and especially for aspirin and heart attack and stroke prevention. Heart attack and stroke prevention is serious business, so don't take chances with heart attack prevention. And that's what I do for a living. And my patients, most of them develop into the same opinion that I have about strokes. Stroke prevention is even more serious than heart attack prevention because stroke is the number one cause of permanent disability, ending up the rest of your life in a wheelchair or bedridden. That stroke is the number one cause of that. So we don't want to mess around with either heart attack or stroke prevention. Now, all this stuff, I admit, it can be a little bit complicated. So if you're looking for medical care where we're open to different treatments, we're open to lifestyle, we acknowledge from the very beginning that yes, medications are important, supplements are important, but nothing is as important as lifestyle. Even all the stuff I've talked about today with NOACs, aspirin, those still aren't as important in preventing heart attack and stroke as the lifestyle components that we've always talked about. Managing your weight, looking for prediabetes, making sure that you manage those risks. How do you do that? And if you're a little bit confused about how to do that, come see us. We're not paternalistic. We respect your decision and support you. Now, what do I mean by paternalistic? In movie vernacular, I'd say, look, you're Luke Skywalker. I'm just Yoda. Luke Skywalker had to fight his own battles, just like you have to make your own decisions and fight your own battles with heart attack prevention, stroke prevention, etc. So if, for example, you say, I can't lose weight or I don't want to lose weight, I understand. I will support you any way I can. If you say, I know I have plaque, but I don't want to take aspirin, I'd rather take turmeric. I get it. I understand. I want to make sure you know the details, but I'll support you any way I can. Even if you have atrial fib and you say, I don't want to take one of those prescription NOACs, one of those prescription blood thinners. I'd rather take baby aspirin. I get it. I want to make sure you know the details, but I will support you. I'll tell you the benefits, the risks, what's known in terms of the evidence, and I'll also tell you what I would do and what I have done in my own situation. So, if you'd like to come see us, check the description at the end of the video or the link and come see us. Now, I mentioned something earlier on that I didn't talk about yet. It's Lp(a). You know, a lot of people think that's a new cardiovascular risk marker. The reality is it's been around for a long time, but doctors did not know what to do to manage Lp(a), so they just didn't look for it. And you still see that with most physicians. They don't look for it. Most physicians don't even know what it is. But a few years ago, a fellow named Bob Harper had a heart attack. And he surprised everybody because he was in his early 50s. He was very fit. He was the trainer for the show, The Biggest Loser. And he had a heart attack. Then, so people started saying, what was going on? His lifestyle was so good. Well, Bob came out and said, I've got Lp(a). I inherited it from my mama. Lp(a) is a cousin of LDL. It's very similar. It's a genetic variation. The docs call them lipoproteins. You don't need to remember that. Lp(a) does increase risk for heart attacks up to 4 times. Aspirin can decrease the increased risk of heart attack and stroke, which comes from Lp(a). It decreases it by a lot, 52%. Now, you've been very patient. This has been a long video. If you've made it this far, I appreciate it. And hopefully you know a lot more about how aspirin works, the benefits, the risks of aspirin, when to take it, and when not to take it. You also know about its use or not use for atrial fib. You know a lot more about atrial fib, about Lp(a). I do focus on lifestyle as the major intervention. We do use medications when appropriate and the patient wants to. Supplements help, and we know about supplements as well. Now, if you want to know how I reversed my arterial plaque, click on this video right here. If you want to become a patient, click this link or the one in the description. It's down below. And thank you so much. Thank you so much for your interest.